Good morning, everyone, and good afternoon. Thank you for joining us today for our investigator skill development seminar series for the Health Disparity Research in Multiple Chronic Diseases Network. I'm Mandana Khalili, professor of medicine and a pathologist at UCSF, with research focused on health disparities in liver diseases, and the director of the Investigator Skill Development Unit. I'm joined by my colleague and our unit co-director, Dr. Edmond Charlebois, who's also a professor of medicine at UCSF and the PI of the Research Coordinating Center for the network. Before we start, I'd like to remind you to mute yourself during the presentation. Also, please feel free to submit questions through chat throughout the presentation and also after the presentation. And if you'd like to ask the questions yourself, please raise your hand after the presentation and I'll be happy to call upon you. Rochelle, would you mind giving us the land acknowledgement? Yes, also. And again, before we start, we would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, future, who call this place the land of UCSF sits upon, their home. We're proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Thank you. Well, I'm honored today to introduce our speaker, Dr. Jennifer Alvidrez, who will be discussing the NIMHD research framework today. Dr. Alvidrez joined the NIH Office of Disease Prevention as a health scientist administrator in August of 2021, where she leads efforts to strengthen research to address health disparity in disease prevention. Before joining the Office of Disease Prevention, Dr. Alvidrez was a program official at the NIMHD. In this role, she managed a diverse portfolio of research, capacity building, and training grants. She also served as a program director for the NIMHD Centers of Excellence program and initiatives on population health in the US-affiliated Pacific Islands, on risk and resilience in Puerto Rico and US Virgin Islands after Hurricane Irma and Maria, and on youth violence preventative interventions that address racism and discrimination. Prior to the NIMHD, she was an associate professor at the Department of Psychiatry in our own UCSF. Her research addressed barriers to mental health care among racial and ethnic minority populations, mental health stigma, mental health treatment of crime victims, and minority inclusion in clinical research. Dr. Alvidrez, we look very much forward to learning from you. Thank you for your attendance.
All right, well, thank you for having me. I recognize some of the names, so I probably talked with you perhaps as you were submitting your applications for this program while I was still at NIMHD. So let me share my slides. Okay, can you see that?
Looks great.
Okay, so yeah, so you heard I'm at the Office of Disease Prevention, not at NIMHD. So why am I giving this talk? I think when the folks reached out to Nate Stinson at NIMHD about who could give a presentation, I think Nate probably gave my name as payback for my leaving NIMHD. No. I was one of the lead developers and kind of proponents of the framework. So that's why, and it's actually used across NIH. So that's why I'm presenting today. So here's the framework. I'm going to describe it more in detail, but just so you can see it at a glance, and then I'll go into more detail, but some background about it. So as NIMHD was going through a science visioning process to really identify priorities, next steps, the future of health disparities research, there was a need to have a framework that could kind of guide health disparities research that NIMHD was going to solicit and support. And we knew, and at this time, there was growing recognition of the social determinants of health, so moving beyond kind of the medical model, particularly in understanding health disparities. So one of the models that is probably very familiar is the socioecological model, which says health, or in this case, it started out as development, child development, but is more than just what an individual is doing, but the context in which an individual lives, the people they're interacting, the systems they interact with. So you've probably seen these concentric circles many times before. This is from now that I'm a Fed, I try to use federal images as much as possible, so we don't have to pay for them. So I took a CDC graphic of the socioecological model. The CDC is kind of acting like they invented it, but this goes way back. The first person to put this on paper was Bronfenbrenner in the late 70s. So this idea has been around for a while. And although this is clearly important in understanding health and health disparities, it's so broad that it doesn't necessarily give you a lot of guidance on, well, what are you supposed to, how do you really conceptualize what's going on here? So we looked at, and this is not coincidental because our director, Eliseo Perez Estable, who is also from UCSF, prior to coming to NIMHD as the director, was on the advisory council of the National Institute of Aging. And he was one of the developers of NIA's health disparities framework, which looks at different domains. So the socioecological model looks at different levels of influence. This framework looks at domains of influence. So biological, behavioral, sociocultural, and environmental. And so this is certainly helpful in thinking about specific determinants that may be relevant to health disparities, but it's at all different levels. So again, it can be hard to conceptualize what determinants may be relevant for specific health conditions, specific disparities. So we kind of combined these two models and sort of made a crosstab of the levels of influence, individual, interpersonal, which includes family, peer, organizational, community, and societal, and crosstab that with domains of influence. So similar to NIA's model, biological, behavioral, we broke environmental into the physical built environment and the sociocultural environment, and then a separate domain for healthcare. So when you crosstab these, you get all these different cells that, so there's a biological individual determinants, behavioral, interpersonal determinants. So there's this whole matrix of determinants that may be relevant to understanding health disparities, and corresponding to the levels of influence for the determinants. There are also levels of health outcomes. So we tend to focus on individual health outcomes, but there are also family and organizational health outcomes, community health outcomes, and population health outcomes. So this is current, what you see on our framework, on our website, under the framework page. And so the purposes of the framework, it's really intended to kind of show the universe of determinants or intervention targets that may be relevant in the health disparities space. It's not meant to suggest that every project has to fill in the boxes and address all the boxes. It's just kind of showing the landscape of what may be important, and to really encourage researchers to move beyond, so going back, to move beyond that individual biological and behavioral space, where a lot of health research and health interventions focus. So there's really all this other stuff going on, and if you're just focusing on a single cell of the framework, you're probably not going to get a lot of traction in really addressing health disparities. We also wanted to emphasize with the framework, like I mentioned, that health outcomes also occur at higher levels beyond the individual. And then we wanted to use the framework as a way to do portfolio analysis to see who's doing what, who's looking at, who's intervening in which areas of the framework, what studies are being funded that address this determinant, that determinant, to really show, are we making progress and moving beyond the individual kind of model? What the framework doesn't do is, it's not a conceptual model itself. It doesn't have directions, arrows, mechanisms, pathways. It doesn't say which cells of the framework may be relevant for particular populations, for particular disparities, for particular health outcomes. It's really just a matrix of possibilities. And it's not meant to be exhaustive. We include some things as examples to help get people started in thinking about these things, but we don't want that to be limiting in any way. So just to show how a conceptual model is different, this is the minority stress model from Elon Meyer. So it identifies specific factors, determinants, mechanisms. It shows arrows linking things to other things, and it identifies specific outcomes. So we don't intend for people to say, my conceptual model is the NIMHD research framework, because it's not a conceptual model. So you still need something like this in addition to using the framework. So how we intend the framework to be used. So NIMHD and many other institutes and centers at NIH now reference the framework in funding opportunity announcements, in presentations, and NIMHD certainly, but my current office, ODP, is using the framework to conduct portfolio analyses. I'll get into that a little in a minute, but so we can see our progress in doing multi-domain, multi-level research. How we hope the extramural community, so you all will use this. You can download it. It's you can use it however you wish. If you do publicize it or distribute it, we just ask that you reference, and there's a suggested citation on the website that can be used in your own presentations, in your own, if you're teaching courses, if you want to publish it. And we encourage folks to adapt it. So it's not set in stone. You can sort of, tinker around with it to suit your needs, to help you think about what are the relevant determinants and domains and levels of influence that are really driving disparities or health outcomes for the work that you do. And to the extent that it's helpful, to include it in grant applications. So again, it's not a conceptual model, but in grant applications that I've seen, particularly if the funding opportunity announcement requires or encourages multi-level, multi-domain research, you can depict the domains and the levels that you're to show that it's actually multi-level or multi-domain. And some applicants find it helpful to use the framework to organize the measures or metrics that they're using, rather than just a straight table. So we encourage folks to use it in a grant application if it's helpful, but it's not a requirement. So just because the framework is referenced in a funding opportunity announcement doesn't mean you are expected to have a little figure of the framework in your application. If it's helpful, great. If it's not, you don't need to use it. So related to the portfolio analyses that I mentioned, so this is an article as part of our science visioning process. We did a special issue in the American Journal of Public Health, and we did an initial analysis of NIMHD's portfolio. So it's not the whole NIH portfolio, about what determinants were being included across which cells of the framework. And so this is not a big sample, and it's kind of old now. Hopefully these numbers would look different, but just to show an initial snapshot as we rolled out the framework, the important thing here is to look at the percentages. So this is the percentage of these 90 R01 grants that included a determinant in these cells. So if you look at the percentages, you can see most of the projects included, and this could be intervention or observational work. There's a lot of focus on the individual level across the domains, except for the physical built environment. So that's clearly a gap, even at the individual level. And then as you look across the levels of influence, the healthcare system is kind of doing more higher level stuff. And that's because NIMHD funds a lot of policy, like health policy research, like Medicaid expansion and things like that. But beyond that, only a minority of any of the projects are using the higher level determinants at any of the domains outside of healthcare. So even though NIMHD, always a big proponent of looking at social determinants, not still a very kind of individual biological behavioral framework, focus of R01 projects. So hopefully if we use this as a benchmark, if we replicated this, there would both be more R01s than 90, and there would be more distribution of the determinants across. So, excuse me, I did mention that we encourage adaptations of the framework. So just wanted to share a couple of those with you. So this is from the Office of Nutrition Research, had convened a work group within NIH to develop a health disparities research framework specific to nutrition. So they adapted, they used the basic organization of the framework and just populated it with nutrition specific determinants, where the original framework is all kinds of determinants. So there are things like the availability of food stamps in food pantries, cultural traditions around food and dietary practices, for example. So this can then be used by the Office of Nutrition Research to do their own portfolio analysis, but it can also encourage projects that they mostly co-fund probably to potentially address some of these determinants. And these are on NIMHD's website. This is from Spira Manson, who has been both a funded investigator as well as a member of the NIMHD's advisory council. Again, using the basic structure of the framework, but adapting it to identify determinants that are particularly relevant for American Indian, Alaska Native populations. So you can see particularly a lot of higher level kind of policies, historical practices, laws and policies like boarding school, removing kids and putting them in boarding schools. So a lot of the historical components, as well as the current context specific to AIA and populations. So some investigators use the basic kind of concept of multi-level, multi-domain in the framework, but sort of re-envision it. So this is one of NIMHD funded investigators who received a vaccine hesitancy R01 award, and they prefer to depict the framework rather than sort of a grid into a Venn diagram, but still reflecting the domains and levels of influence. And then another one from Kiawe Kaholakula at University of Hawaii sort of took the look of the framework and really focused on the domains of influence that are really specific to Native Hawaiian populations. So it's all good. However, researchers or others want to take the framework and sort of run with it in either retaining the look or format of the framework or just going in a different direction and using it as a starting point. We totally are supportive of that, and NIMHD will put adaptations of the framework on its website. And then potentially others who are working in the same area can see the framework, maybe include some of the determinants that are identified as important, or maybe even work together on these topics. So let's see, is that it? Yes, that's actually all I wanted to present. So I'm happy to answer any questions. And if anyone has questions about the Office of Disease Prevention, where I currently work, I'm certainly happy to answer questions about that as well.
Thank you so much, Dr. Alvarez, for that wonderful presentation and quite a lot of information to absorb as well. We have a question in the chat by Dr. Gansky, who asks, where do you envision commercial industrial determinants belonging in the framework? Is it societal behavior, societal sociocultural, or somewhere else?
Right, so let's see. Can go back. So as you get to the higher levels of influence, it can kind of be not so clear, is something societal behavioral or societal sociocultural environment. So, and in the article where we introduced the framework, we kind of acknowledge that. It also kind of doesn't matter. It's sort of, you could put it where you want, and as long as you're doing it, right? As long as you're getting up into those higher levels, that's what's important, not specifically. The most important thing is to get out of the individual biological and behavioral boxes and just, you know, rather than staying locked in those boxes, to expand out. So to your specific question, I think it depends on what specifically you're talking about where things would fit, right? So there are things happening at the local level regarding businesses and decisions about where to locate power plants. And then there are state and federal kind of policies and laws and regulations and enforcement of those things. So it would probably depend on what specifically you're looking at, about where I might fit it in. But I think it's more important just to look at those kinds of things, rather than just, you know, sort of not looking at the context in which people, you know, live, work, learn, play, pray, and all those things.
Thank you. Dr. Stewart, does that address your question?
Yeah, and as I wrote in as a follow-up in the chat, I think the example you gave, focusing on nutrition and diet, helped illustrate that for me, because the two main sort of industry or commercial influences that I've been thinking about, have colleagues who work in those areas, are tobacco and sugar. And so those can fall into marketing. And so I think one of the examples was, I guess, maybe on built environment, and maybe thinking about like billboards in a community, or other kinds of advertisements that people see. Or it could be behavioral, where an example was a soda tax, a local soda tax, or a state soda tax, so that it's related to the policies and laws as shown on this slide. And then I do think there would be some places for social norms, particularly for tobacco, and whether, you know, people tolerate smokers, where smokers have to go to use cigarettes or other smoke products, and or vaping and those kinds of things. So I think, yeah, it could fall in any of those.
Right. And I think the framework, what the framework intends to do is to sort of encourage you to think about, well, there's sort of peer norms, right, of your peer group and how smoking is accepted, or family. And then the local neighborhood about whether there are taxes, whether things are prohibited. And then states may have their own laws. And then at the societal level about kind of messaging around tobacco, as well as any laws. So to really think about all the different levels that some of those determinants might be operating at.
Thank you. Maybe a question for you, Dr. Alvader, is about, in reading the article that that was just published about the portfolios of the grants. I noticed that there was a reference to many sort of lacked accounting for life course. And I was wondering if you could comment on what is exactly meant by that and how can we be doing better in that regard?
Right. And the framework itself isn't all that accountable to life course factors. There's just a little kind of under the domain of influence. It says over the life course, right? So we didn't quite know where to put it. I think an overlay of all of this is the specific populations, and then kind of where in the life course or cumulatively over the life course. So I think very few of the R01s that we looked at really addressed life course issues at all. So either just include adults from 18 to whatever, and not really looking, or just looking at a particular, not really taking into account developmental issues, critical periods, generational transmission of risk or protective factors, those kinds of things. So yeah, it's always a challenge to know how to encourage a life course perspective. Does that just mean we're interested in age 0 to 100 and whatever? Or does it mean you should really look at life course issues like developmental periods and generational processes? So how's that for a non-answer?
Thank you. That was great. Maybe another question as we're waiting for others to weigh in. This is with respect to sort of addressing some of the learning points for our junior investigators. You had kindly indicated that, this is a framework and it really isn't a conceptual model. Could you sort of provide us with some guidance about, in looking at in all of these factors, many of which are important influences, how does one go about sort of developing the conceptual model, whether it be a few, whether it be some from each of those domains? What is your approach to that?
Mm-hmm. Right. So I think the literature, which includes prior conceptual models and associations or pathways or causal associations that have been identified to show what's important, but also about partners. So community partners, healthcare partners, of saying, this is what's really driving, this is what is really driving a disparity in this case, or this is what is keeping our community from being able to whatever the optimal health outcome is, right? So it's both a combination of kind of the existing evidence and conceptual thinking, as well as whatever context you're working, all of the potential partners and their perspectives on what is important to look at.
Very helpful. Thank you. Dr. Charlebois, I know that you had a particular question in mind regarding the efforts of our initiative. please go ahead.
Sure. Well, I don't know if the audience knows, but Dr. Alvarez was intimately involved with the creation of the RFA for this multiple chronic diseases disparities research initiative within NIMHD. So I had a question for you, Dr. Alvarez. We're particularly focusing on social determinants of health, and because we're looking at common pathways, the areas of interest that we're trying to understand and intervene on in this initiative are over to the right-hand side when you're looking at levels of influence, and with some variation in over the domains. When utilizing a framework like this, what are some of the ways individual centers and some of the pilot projects that are occurring within this initiative can take the best use of the framework? Frameworks from implementation science, we're often using our frameworks to ensure that we're looking at the totality or completeness of the realm of influences. But how can we use the framework to do what we want to do within this initiative better?
Mm-hmm. Right. And it was just circulated around NIH about the latest congressional budget bill, who kind of gave the thumbs up to continuing funding for these chronic disease centers. So just an aside. I think the impetus really for the chronic disease centers from Congress was really about breaking down silos and not kind of replicating the same work and sort of fill in the blank for the health outcome. So I think to maybe identify common risk factors, common pathways that lead to multiple health disparities or certain health outcomes across chronic conditions. But I also think it's important to look at disease or health condition specific determinants, right? Because you kind of need to intervene on both, right? The general and the specific. Congress is more coming at it from common, co-occurring health conditions. So start early on so you can prevent all of them or prevent the progression of multiple diseases at once, right? But they're still, so I would almost use the framework to identify those general ones and then identify some health condition specific ones to sort of strategize a comprehensive strategy to address these disparities. Does that help?
Yes, I think so. And applying this, at all stages of your development, when you're initially identifying things for the pilot projects, and then as we're choosing our common measures, we're definitely the Common Data Elements group under the leadership of Dr. Gansky, and I would definitely using this framework and others to ensure the completeness of the range of common data elements that we're going to be collecting and analyzing across this initiative.
Maybe I can ask you another question, Dr. Alvarez. This is in regards to your significant contribution and work in the area of structural racism and discrimination. And I know a topic on many of our minds. And I wanted to get your thoughts about how you would think certain aspects of these issues sort of relate to the population health. How can we see the linkage, and how can we do better in addressing them?
Mm-hmm. Right. I think, and I can tell you some inside information. When a colleague and I first presented the framework to our director, we actually wanted racism and discrimination to be its own domain. It was probably before its time. if we presented that today, if we were just doing the framework today, it would probably go in there. We did want to make sure that there was racism and discrimination in all of the levels. So, and I think even the work on racism has focused on the individual. So the whole concept of internalized racism or internalized stigma really is about an individual's response to these societal factors, right? And so a lot of the work has been on first identifying the health impacts of racism and discrimination. I think we know enough now to know that it's not good, right? That we don't have to study every conceivable sort of association and replicate, yeah, experiencing racism is not good for you. It's not good for your health. But I think also moving away from the response to being a victim of racism and discrimination to changing the racism and discrimination at these different levels, whether it's happening in the schools, in the workplace, in the community, in the neighborhood, in the criminal justice system, in the educational system, in the occupational system, housing, right? And not just use the individual and their response is how we conceptualize intervening regarding racism and discrimination. And I will tell you that the RFA that we did allowed for both observational and intervention. We got many more observational. I can't go into too many details because no funding, there's nothing funded yet. And so I think it's still kind of a paradigm shift to think about intervening on structural racism, not just helping people deal with it or become more resilient or work around it or navigate through it or all these other things, right? Which puts the burden of dealing with structural racism on the victims of it, which doesn't seem very fair, right? So, and thinking, well, health researchers, that's not what we do. Maybe bias in the healthcare system, we can tackle as health researchers, but in the criminal justice system, that's not something that we do. And I think if we're health researchers and we are trying to eliminate health disparities, then everything that's driving it falls within our domain of potentially looking at how to address it, even if it takes us outside of the healthcare system. And I think that's not how we were brought up, right? That's not how I was brought up in my training, to just work, to do psychotherapy with individuals. We didn't talk about structural racism and what can we do about that. So I think it really is a shift that the health research field needs to take.
Wonderful. Do you think, Dr. Ehlers, if maybe the basis of the social determinants of health assessment or intervention really stems from which is again another area of focus, stems from this structural discrimination and racism to begin with?
Yeah, I mean, I think, the idea of fundamental causes and the inequitable sort of allocation of resources as driving all of the inequities that you see downstream, right? So I think some of the impetus in the health field for addressing social determinants is even if you have similar access to healthcare, right? So the same insurance status, you still see these disparities. And why is that? We're offering, theoretically, we're offering the same treatments, we're offering the same, why do we still see these disparities? Oh, it's because these things that are going on. And I think the first generation, like precision medicine, is really about understanding the impact of social determinants on health, social determinants of health to explain an individual's health status, not necessarily to intervene on those social determinants, to just go, this person, had adverse childhood experiences. That explains blank, right? So really to understand but not do. So I hope we're going to move into actually healthcare systems taking on social determinants, right? The sort of awkward phase in between is we have to measure, we have to capture it in the EHR, we have to assess, and then what are we supposed to do? Right. So move into the action phase and do things like partnerships, like medical legal partnerships. If part of why your patient's asthma isn't getting better is because they're living in substandard housing where there's mold and cockroaches and landlords aren't doing anything about it, partnering with legal assistance, you know, to get that housing cleaned up can still be part of the healthcare system's responsibility.
Thank you. We have someone's hands up. Dr. Laborossi? I'm sorry, I'm not seeing the name clearly. Laborosier, sorry, please introduce yourself. Thank you.
Hi, I am a first year PhD student at UMass Chan Medical School. Yeah, and thank you for this talk. So I'm actually working on a project related to polysocial risk score. So, so the idea that I have in terms of, and going back to what you mentioned, Dr. Alvidrez, to address structural racism in the context of healthcare is the fact that when it comes to, once we identify those social determinants of health, how can we make sure that we have a like a unified system in terms of the medical, you know, via my chart, but where, you know, physician can have this discussion with patient in terms of if they are at risk of lack of food or housing, but then to be able to capture it in a way where we can see the disparities and we can look at it from a local or, you know, neighborhood level. Because to me, I think that, you know, in order for us to address structural racism, well, I mean, one of the ways is to have this unified language in terms of how we identify it, how we measure it, and how we can take it to the next step in terms of if services are not available in that particular community, why? And if you also consider intersectionality as well, you know, this is something in terms of if you are someone, let's say from the LGBTQ community, you need mental health services, you know, tailored to you. How can we approach it that way? So do you have any thoughts on how we can make sure our healthcare system have this unified way? I am thinking about my chart in terms of like electronic medical, but how can we have this unified language or this metric that we can see, okay, this is what's going on and what can we do in, you know, in communities that are impacted by that?
Right. Well, gosh, that's a simple question. I think, yeah, I mean, I think the first wave was really trying to capture the social determinants in EHRs before knowing what you're going to do about it when you identify someone has food insecurity or housing insecurity, right? And then I think, like, you see these generations or waves of documenting it and just understanding what's going on and understanding when your patient doesn't show up. And then I think knowing that maybe you have to provide referrals, right, to maybe a food bank, or maybe there's even a food bank partnership with your hospital. And the next step would be health professionals and hospitals working with the food banks or the farmers markets to address the food landscape in the community, right? I mean, so, and how does all that happen? I think that also brings up what is reimbursable, right? And sort of what can healthcare providers get reimbursed for doing, which is, so you see, I think you see organizations like Kaiser, right, which is a closed system. It can kind of address social determinants by providing transportation, food, you know, all these things, but it's kind of, it's not, you can't just do that. Like Medicaid providers can't do that, right, what Kaiser can do. So I think it's really about sort of re-envisioning what healthcare is. And it's more than just going to the doctor after you get sick, right? And that's a challenge because someone has to pay for it, even though healthy people are cheaper than sick people, right? So it saves money to promote wellness, but kind of our payment systems and reimbursement systems aren't set up for that. So it requires, I think, demonstrating that these can actually be cost savings, cost effective, if not cost savings, to really engage in some of these things that are considered outside of the domain of healthcare.
Hi, I can't find how to raise my hand on the Zoom, but I wanted, if you don't mind, I have a kind of a question or a response to Stefan. I was part of a pilot project in Florida that did a social determinants of health screening to patients in HIV and WIC clinics. And I would pull patients aside so the doctors didn't have to do the screenings themselves because, you know, they have very limited time in hospitals to even just assess a patient, which was one of the issues we came across. And so then I would reconnect patients to all of the community resources that were available to the community members if they had a problem or ticked off something that they wanted help with. And we ran into massive barriers in doing this because even if there are community services available, they're so overwhelmed that we couldn't actually get anyone help. I maybe out of like the hundreds of people that I screened was able to actually find one person help. So like we had this central system where I could then like refer all these people to all these different organizations, but we ended up not actually being able to do anything with that information. So like you can tell me you need help, but then I can't actually do anything with it. And so that was kind of like I think that's going to be the barrier that you're going to end up facing in this, which is a great idea, right? It works out in theory, but then it's hard to implement once you realize that the community resources aren't able to respond to the needs of the community.
Yes, thank you for that, Brenton. I appreciate it. Yeah. Mm-hmm. Yeah, and I think that once we are able to, you know, again, find a way through GIS, but to see that and how we can take further steps, because especially after 2020, with the COVID pandemic, these issues have exacerbated. So moving forward, we really need to revamp in terms of what healthcare means, but also how we can also address those factors that were impacted, like housing, food insecurity. People are still experiencing those things. So yes, thank you for that. So that's food for thought.
Thank you. Steffi Kim, please introduce yourself.
Yeah, hi, my name is Steffi Kim. I'm a clinical community psychologist, and I'm located in Anchorage, Alaska, but I'm now with a Memory Keepers medical discovery team and at the University of Minnesota. And so in my clinical training, I have worked in a community clinic here in Anchorage, and they have the model of being a patient-centered medical home. And that's exactly what we did. We did have a social worker. We have behavioral health that went in and saw the patients whenever they needed to be seen by a clinician. And so social work, clinical workers, we all kind of worked together to address whatever kind of needs were needed. If it was housing, we partnered with different housing corporations within Anchorage. If it was a mental health clinic or a mental health issue that we couldn't capture yet, we sent them to a different clinic and made sure they were accepted in that clinic as well. So we would provide follow-up to make sure they get there. If we also work together with an advocate for the LGBTQ community. So we kind of were able to connect quite well with these established relationships within the community. But of course, even we saw that sometimes that didn't work, and sometimes for some people, the needs were too high. But we also worked with the food bank and were able to connect them with folks from there, but also provided sometimes just vouchers to go to be, it was a $20 voucher, you qualify for this, here you go and get some food at the farmer's market. So we were able to provide some of those services and it worked quite well. Obviously not all of it. I mean, there's way more to do, but it was a nice way of seeing if people work together and the system is set up in such a way, it can be done.
Yeah, and I think also in thinking more holistically about what healthcare clinicians can offer as prescriptions, so food as medicine, housing vouchers as a prescription, physical activity, or membership at a fitness club, you know, like it's not just medication that maybe can be prescribed. And I think there is lots of evidence that if you just, and the article about, I think it's the one about reducing kids' hospitalizations, if you address some of the housing insecurity or housing issues, but also the raising the state minimum wage laws results in fewer babies dying, like lower infant mortality rates, right? I mean, so just offering a little assistance to help people meet their survival needs can have a tremendous population impact for morbidity and mortality.
Any other questions? Dr. Gensky, I know you had submitted an article through chat.
I see. Oh, no.
Yeah, so Dr. Alvarez had given the example of a medical legal partnership, particularly for housing. And I know that Cincinnati Children's Hospital has published on some of that. And there's actually just a new paper out which shows more widespread impacts than their previous work that's been published. So it's one example, but of course, you know, as the last person was talking, you need to have the partnership, you need to have the place that gets the referral to have the capacity to handle the extra volume. So that's, you know, as a partnership, it needs to be worked out ahead of time and together.
Abby, I see that you have a comment there. Do you want to verbally express it?
Oh, sure.
And please introduce yourself.
Hi, my name is Abby Lohr, and I am a postdoc at the Mayo Clinic in Rochester, Minnesota, which is part of the P Award at the University of Minnesota. And prior to this work, I did some work with community health workers, and we were looking at community clinical linkages supported by community health workers. And we touched on some of the things that Dr. Alvarez mentioned and the importance of referring folks. But I'll also add that a referral sometimes isn't enough, that follow-up is really key. And so I put in the link a paper we wrote about with examples of cases where community health workers not only referred, but also followed up with folks and how that was crucial to improving health outcomes.
Thank you for that. This is your chance to be asking our expert about some of your projects perhaps as well. Please feel free to share with us any lingering questions. Dr. Alvarez, maybe in the last few minutes, as I'm waiting for other questions to come in, would you like to talk to us a little bit about your work at the Office of Health Prevention?
Sure. So I joined ODP, Office of Disease Prevention, because they were starting a new health disparities team. So that's exciting to start a new health disparities team. So the offices, unlike the institutes and centers, work sort of trans NIH, sort of coordinating and bringing all the different institutes and centers together to maybe leverage and work together and collaborate and do things maybe individual ICs would have trouble doing on their own. So part of what this new team is doing is it's working across NIH to develop, so eventually develop funding opportunity announcements to promote more prevention interventions specifically in populations that experience health disparities. So be on the lookout for those over the next couple of years to come out. The portfolio analyses that the office did showed that even though there's a lot of work that is kind of categorized as prevention, the majority is not intervention work. It's sort of pre-intervention work. And then less than 1% of the total NIH portfolio is devoted to prevention interventions of leading risk factors for causes of death and disability in populations that experience health disparities. So nowhere near enough to make a dent in generating the evidence base to eliminate disparities. So that's what my team is going to be working on for the next few years.
Wonderful. Well, thank you so much for a great presentation. And I really want to thank the audience for their participation. Please feel free to share with us any thoughts, any ways that we can certainly do better in providing you with information. And please don't forget to complete your surveys. Dr. Avila-Torres, I wanted to thank you very much for this wonderful session and in giving us the honor of being here. Thank you, everyone.
For having me.
Bye-bye.
Thank you.
Thank you.